All right. Hi, everyone. So we're just going to give it one more minute for people to log in. So while everyone's logging in, I do have just a quick polling question in the beginning, just to see who is in the room in terms of your organization that you're representing today. So you'll see a poll that has just launched on your screen. The question really is, which of the following best describes your organization type? Just to acknowledge that this webinar has been created for the health center audience. So that includes the FQHCs, the health center control networks, the primary care associations, but we always welcome other non-health center audience members in the room just to learn about what health centers are doing on the ground in terms of diabetes. So please take that poll in the next 30 seconds and we'll start the webinar in just a second. All right, thank you for those participating in the poll. So again, it looks like a majority of our audience today are health centers and with some government and other types of organizations in the room. So appreciate all of you for joining today's webinar. All right, so we're gonna get started. So hello all and welcome again to today's session. If you're rejoining us from any of the previous 3 webinars, thank you for spending part of your time with us again. On behalf of the Special and Vulnerable Populations Task Force, I'd like to welcome you all again to the 4th and final webinar in our 4-part learning series that's focused on specific areas of the diabetes continuum of care framework, which is based on the HRSA diabetes quality improvement initiatives and also feedback from the health centers in 2019. Similar to the format of webinar number 2 in this series, today's 90-minute session will have a formal presentation followed by a facilitated panel discussion featuring 4 guest speakers that represent health centers and community-based organizations, hence the pillars of community engagement, which is the topic for today. So you're in store for a treat on this Tuesday. So I am Albert Eisen. I am the Senior Program Manager of Training and Technical Assistance at the Association of Asian Pacific Community Health Organizations, or also known as APSHO, and I'll be serving as your moderator again today. I also want to acknowledge my colleagues, Joe Lee and Christine Alarcon from APSHO, as well as Jillian Hopewell from the Migrant Clinicians Network. The 4 of us combined have served as the moderators and behind the scenes organizers for the learning series. So thank you to my colleagues. Before we get into the content, and some of you are already familiar with Zoom, I just want to go over some of the main features that we'll be using and engaging with today. The first is the audio. So if you click the mute unmute button, that allows you to use your microphone. But however, to minimize background noise, since there are hundreds of attendees on this webinar, we are going to leave everyone unmuted upon entry. If you click the up arrow button or the triangle right next to the mute unmute button, that allows you to choose specific audio settings for your microphone or speaker. So again, some of you may be using your phone today and others may be using your desktop. So just be mindful of which one you're using. All right, the next feature is the Q&A pod. So during the presentation, you may be able to tailor your questions to specific presenters or just to the general audience. Just simply click the Q&A and type your questions into the free text field as you see here on the screen. The moderators and organizers, as well as the guest panelists, will either send a typed response to your question or answer the question live if there's time permitting at the end. You all as attendees can either upvote or comment on any of the questions that have been posed by your fellow attendees. Just use again, this button, upvote, and then the comment section here. We do have about an hour and a half together, so I encourage you all to monitor the Q&A pod and virtually engage with each other this way. All right, so the next feature is the chat box. So you can use the chat box to communicate with the panelists, the moderators, and other attendees as well anytime during the session. Be ready to chat with us during some of the open-ended questions that may be posed from the speakers. You can also chat with my colleague Joe Lee for any of the Zoom troubleshooting issues. As for the content and speaker-related questions, I want to point you back to the Q&A pod to make sure that all the other attendees can upvote or comment on similar questions that you may have. All right. Last is the raise hand and lower hand button here. It's not really used a lot in the series, but if you do end up using it, we'll chat with you on the side to see if you have a specific question or issue on your end. If you accidentally click the raise hand, just simply click it again and it'll lower the icon. So before you all end and leave today's session, I encourage you all to, again, take the post-webinar survey that's going to be prompted in SurveyMonkey. This feedback is going to be helpful in determining next year's series in 2021. So your suggestions for content, speakers, format is really helpful. The other important aspect of the survey is for those of you participating for continuing education credits, whether that's the CNEs or CMEs, in order for you to get the certificates from our colleagues at the Migrant Clinicians Network, you'll have to complete the surveys and provide your information so that we can send our certificate to you electronically or by mail. So please be mindful of that. And if you have to hop off early, that's okay. We just ask that you, again, take the survey at the end. All right, so quickly on the series as we wrap up today with the fourth webinar. This National Learning Series was created to address our nation's diabetes epidemic, which is affecting more than 30 million people across the US. In terms of the health center population, according to the 2018 UDS, about 1 in 7 health center patients has diabetes, and about 1 in 3 of those patients has uncontrolled diabetes. So it's a prevalent and growing issue within the health center population, and this is why the Special and Vulnerable Populations Task Force has created a series of content and subject matter expertise to really talk about strategies that they've used to prevent, treat, and manage diabetes amongst their health center populations. We also want to take this time to acknowledge HRSA for their support of the task force in this learning series, as we all try to combat and address, again, both prevention and management. And when we say the Special and Vulnerable Populations Task Force, these are the 14 organizations or National Cooperative Agreement holders that are funded by HRSA and are all dedicated to improving the health of special and vulnerable populations. We have been collaborating for the past 8 months to make this content meaningful and coordinated. So we thank all the NCA faculty for, again, giving us access to their expertise and also to their network of experts as well. For more information about these NCA partners, please visit diabetes.appshow.org, which is available again at the bottom of this slide. Just a quick reminder again, the webinar series is making CMEs and CNEs available to you all needing continuing education. Just simply fill out the webinar evaluation at the end with your information, and you can also contact Martha Alvarado at the Migrant Clinicians Network for any questions you have. You might get another email in the subsequent days just to confirm your information, so that way your certificates are emailed or mailed to the correct address. If you did miss the first 3 webinars of this series, rest assured that they are now available, all slides and recordings of these on diabetes.appshow.org. Again, as a reminder, we had team-based care as one big topic and health literacy as another big topic. And today we conclude with community engagement. And to acknowledge the current crisis we're in, just want to acknowledge that the task force and the health center partners have been addressing the COVID-19 epidemic and pandemic by providing resources on the Health Center Resource Clearinghouse. So if you click on this link after you get the slides on your end, it'll direct you to the Health Center Resource Clearinghouse, which has been vetted with many other organizations' web pages and resources around, again, the coronavirus. And go to the priority topics at the top of the webpage, and there is a quick link to the COVID-19 page, which again has plenty of resources that are updated daily or weekly from 20 different organizations, including the task force members on this call. So, and Joe, my colleague, can type that link in for those of you that want to visit it. And just quickly again, according to our partners at the ADA or American Diabetes Association and the CDC, we are acknowledging that people with diabetes are not more likely to get COVID-19 than the general population. However, people with underlying chronic medical conditions like heart disease, lung disease, or diabetes do seem to be at higher risk for developing more serious symptoms and complications when infected with the virus. So this really is a call to action to make sure that we are addressing our patients' needs on managing their diabetes so that they aren't as risky for getting sick or severely sick from the COVID-19. And you can find, again, a bunch of resources on these well-informed and well-updated websites like the ADA, the Association of Diabetes Care and Education Specialists, CDC, and Johnson Diabetes, in addition to the Clearinghouse. So to get us moving into the content for today, we do have 3 learning objectives outlined here on the slide. The first being to define community partnerships and explain their importance in addressing diabetes in a primary care setting. The second is identify strategies for increasing and strengthening community partnerships to address diabetes prevention. And the third is to give examples to you all how community engagement facilitates the engagement of diverse patient populations into effective diabetes care and management. And these learning objectives will be, again, addressed by our series of speakers here, starting with our National Cooperative faculty. First, we have from left to right, Alan Gamboa. Alan is APSHO's Pacific Islander Diabetes Prevention Program Director, and he leads the program working with community health centers and community-based organizations to build infrastructure for delivery of the evidence-based lifestyle change program to prevent or delay the onset of type 2 diabetes among adults with prediabetes. Alan has 8 years of prior experience working in the health centers through different roles, including an associate director for Family Health Centers of San Diego, as well as operations for a school-based health center at La Clínica de la Raza in Oakland, California. Alan holds a master's in healthcare administration and interprofessional leadership from the University of California, San Francisco, as well as a bachelor's of science in public health science from the University of California, Irvine. Next is Joe Lee, who is APSHO's Training and Technical Assistance Director. He oversees the National Training and Technical Assistance, as well as consulting activities with health centers and partner organizations. Joe is principally responsible for program development, planning, monitoring, operations, and evaluation work related to APSHO's National Cooperative Agreement under the Bureau of Primary Health Care. And Joe also holds a master's in healthcare administration and interprofessional leadership from UC San Francisco, and then a bachelor's of arts degrees in interdisciplinary studies from the University of California, Berkeley. So 2 Californians in the house. Next is Emily Kane, who is the senior program manager for the National Nurse-Led Care Consortium's training and technical assistance work. Prior to joining NNCC, Emily managed a statewide medical home initiative project in Pennsylvania for pediatric primary care providers. And Emily holds a master's in public administration from Villanova University and a bachelor's degree from Emerson College. Next is Jillian Hopewell, who is the Director of Education and Professional Development at the Migrant Clinicians Network, which is the oldest and largest clinical network dedicated to improving healthcare for underserved migrants. In this capacity, Jillian oversees MCN's Comprehensive Technical Assistance Program for migrant and community health centers, as well as migrant clinicians. Jillian has a master's from the LBJ School of Public Affairs from UT Austin, and also a master's of arts from the Institute of Latin American Studies at UT Austin. And our last faculty from the NCA group is Miranda Robinson Perez, who is the program manager at the School-Based Health Alliance, working on supporting numerous initiatives, including the National Quality Initiative, School Oral Health, Alliance State Leaders, and Screening Brief Intervention Referral, or SBIRT, in school-based health centers. Miranda is a recent MPH graduate with over 10 years of experience in software technology. She graduated from Scripps College in Claremont, California, with a dual major in media studies and women's studies. In 2017, Miranda returned to school to pursue her MPH at George Washington University, where she marries her passion for assessing systematic inequalities with action. All right, and with our 4 guest panelists today, I'm going to read their bios quickly so that way we can get into the fun content. We have first Cindy Whitlock. She is the Director of School Health from New River Health, which is based in West Virginia. Cindy serves on the board of directors of Action Southern West Virginia, past president of Women's Resource Center, charter member of the West Virginia ACES Coalition, and is a candidate for the Fayette County Schools Board of Education. New River Health has built a reputation for their support of the communities they serve through collaborative activities and events, sharing time and resources, and building community capacities for wellness and healthy choices at all ages. Next, we have Dr. Malia Purdy, who is the Director of Programs at Malama Ikeola Health Center based in Maui or Hawaii. Dr. Purdy is the Director of Program for an FQHC and earned her PhD in Public Health with a focus on translational research, emphasizing community-based participatory research, and holds a MPH degree specializing in Native Hawaiian and Indigenous health. Dr. Purdy's primary area of interest is community-driven programs as a mechanism to ensure and sustain interventions that are aimed to address the needs of the community. And her role at Malama Ikeola allows her to oversee cultural and community-driven initiatives like the CDC Pacific Islander Diabetes Prevention Program. And next we have is Lizz Tooher, who is the nurse supervisor for the Mabel Morris Family Home Visit Program. She leads a team of public health nurses bringing evidence-based family home visiting to Philadelphia families. Lizz completed her nursing degree in 2012 and her MPH in 2017 from Drexel University. Currently, Lizz is a fellow in Pennsylvania's Office of Child Development and Early Learning Fellowship Program, advocating and expanding her reach while working amongst the diverse communities in the great city of Philadelphia. And last but not least, we have Saida Sanchez, who is a health educator at Golden Valley Health Center in Central Valley, California. She has been with Golden Valley for over a decade, helping the underserved with chronic disease self-management. She received a BA in Latin American Studies from Notre Dame in Belmont and an MPH from San Jose State University. She counsels people with diabetes on disease management by exploring barriers to healthy eating and physical activity. And Saida is also interested in promoting health in the family nuclei as well as in the environment. So with that, I am excited to start this presentation with Emily Kane from the National Nurse Care Consortium.
Great. Thank you, Albert and Joe, for organizing this and all of our team. And thank all of you for taking the time out of your day and during this crisis, particularly to really engage with us about diabetes and supporting patients and families at health centers. We really appreciate the time you're taking to be with us today and all that you do every day. So we wanted to take this webinar as an opportunity to dive a little bit deeper into community engagement. So community engagement has been central to health centers since their inception and is featured as one of the strategies HRSA recommends to improve health outcomes and reduce health disparities for patients with diabetes. So based on the framework you see on your screen, as well as a survey we sent out to participants from last year's Diabetes Learning Series, the Special and Vulnerable Populations Diabetes Task Force identified community engagement as a critical element on the diabetes continuum of care. Next slide. So what is community engagement? Our faculty combed through many definitions, case studies, and examples of exemplary community engagement and found that there were three common pillars that underpin successful engagement efforts. Those pillars include data-driven decision-making, cultural humility, and strong community partnerships. In other words, engaging the community means understanding important data about the community's environment and makeup, approaching community members with cultural humility, and creating and sustaining robust partnerships that represent the community's interests. Next slide, please. The CDC created a really helpful framework to consider when pursuing partnerships in our communities, so that important partnerships piece. This linkage framework encourages us to follow clear steps to engage partners, beginning with scanning the environment and learning about available resources, developing shared goals, and creating a sustainable operational structure that is agreed upon by all parties. Finally, it's critically important to evaluate the efficacy of the linkages we create with partners. Select outcome measures that are meaningful to your clients and organizations, such as health measures or reported self-satisfaction. So I'd actually like to pull up a poll at this point, just to get a sense from your brief introduction to the linkage framework about which of these letters on the linkage acronym are represent one of the elements that you'd like to explore more. So which of the linkage letters and sort of the task associated with that letter is of most interest to you and your organization? We'll give everyone a few seconds to vote on that poll.
They're trickling in, Emily, so we're about 25% of the attendees right now.
Great, thanks so much, everyone.
So give it 15 more seconds max. So cast your votes and poll now, and then I'll project it for you all to see.
Okay, great. So that educational piece about learning about fellow community and clinical partners, that's great. It's good to know, good to see which is most of interest to everyone so far. And we'll be touching on each of these throughout the presentation. Thanks so much. With that, I'm going to turn it over to Jillian Hopewell, who's going to tell us a little bit about the history of community engagement and SDOH in health centers.
Hey everybody, so happy to see all of you here today, or hear all of you, I guess. I'm just going to take a couple minutes and just to place what we're talking about today in context and remind all of you about the really essential nature of the health center movement and its connections with community engagement, going back to the first community health center and Jack Geiger, and who really was, his vision was really combining community-oriented primary care, public health interventions with civil rights and community empowerment and development initiatives. So really this understanding from the very beginning that healthcare had to take place within the context of community, and that community linkages within that context were essential to making this happen. Next slide, Albert. And then again, look at this graphic, which many of you have seen many different times, but looking at what we're talking about today within the context of social determinants of health. And if you look at really those last two arcs, the purple arc and the green arc, looking at education, work environment, living and working conditions, water and sanitation, and the overall socioeconomic, cultural, and environmental conditions in which our patients live and work. This is really the place where health centers can take the care that they provide to their patients so much further by engaging in community linkages in these areas to really address the multitude of issues that their patients confront. And that is just my brief placing this into context for everybody else, and we're going to move on to looking at the first pillar.
Great, thanks, Jillian. Sorry about the echo, folks. We'll troubleshoot those issues as they come up. Let us know if you hear anything in the chat. So before we engage our patients and communities, we really need to understand the environments where we provide care and services. And that really is represented by this data pillar that we see here. Next slide. For example, you might want to provide your patients with referrals to local food banks or recreational facilities. But if your patients are in an area without access to public transportation or the ability to reach the partners you refer to, those referrals might not be effective. So we need data about what our patients are experiencing in their environment to build appropriate sustainable partnerships. And in addition, we need to understand the most pressing challenges our communities are facing, whether that's housing, access to healthy foods, or another social determinant of health, as Jillian just described. We may think we can pinpoint the greatest challenge our patients experience, but the data could paint a different picture. So on the next few slides, we'll examine some of the sources of data that you can use to identify community needs. For example, as health centers, you already conduct needs assessments to identify services to meet your patients' health and wellness needs. Your needs assessments are great sources of data to inform potential partnerships. Other sources include demographic data, data about income and education, data that illuminates patients' access to food and outdoor space, as well as public transit and pollution levels. Our faculty are happy to help you identify where to locate these data, and we'll be going over some examples. But before we do that, I want to just hear from everyone in the chat. If you currently use any of these sources of data to inform clinical programs, community engagement, or other initiatives at your health center. I'd love to hear from you in the chat. What, if any of these, do you use, or do you use other sources of data that aren't listed here? So feel free to chat that. Make sure you click all panelists and attendees to chat so that it is shared with everybody. And thanks for doing that for us. We'll go to the next slide and we'll kind of dive into that first piece of data, which is socioeconomic data about local communities. So Jillian discussed the social determinants of health and the socio-ecological model of SDOH. And so it's important to dive deeper in understanding the macro, community, interpersonal, and intrapersonal determinants that play a role in patient and community health. So consider accessing data that addresses the social ecological components that influence health outcomes, including the available socioeconomic data about your patients. So for example, we know that access to financial resources has a significant effect on health and well-being. If the communities you serve are low income or chronically unemployed, recommendations about joining a gym or purchasing more expensive healthy foods to control with diabetes may be untenable. We just quote an example here, the UDS Mapper. If you log onto the UDS Mapper, which is a free tool for use, you can see some of those population indicators, and that's mapped out for you on a zip code level. So it might be a great resource to use when understanding some of those socioeconomic factors. Next slide. Socioeconomic data aren't the only SDOH considerations. We also want to find out about our patients' access to the critical resources to facilitate wellness, such as adequate and secure housing, safe outdoor spaces, and clean air. So how does a patient's built environment, the place where they live, influence their outcomes, for example? So a great example of this type of data source is county health rankings. If you Google county health rankings, we can also send this in the chat. You can explore county level data about some of these factors. Next slide. And I'd also love to hear in the chat, as you guys continue to share, about whether you analyze your health center information, including health outcomes, demographics, and service utilization, to identify gaps in care or overall needs that can be addressed with community partnerships. Another consideration about data is that your potential partners, like specialists, hospitals, and academic partners, may have data about their clients that could inform next steps for you and other community members. And here we just quoted UDS measures that may give you a macro level look at some of the important considerations, outcome considerations for health center patients. Next slide. And finally, how can the needs assessment that your health center conducts each year, influence community engagement and outreach? It may also be helpful to incorporate findings from other needs assessment data from healthcare organizations like hospitals or insurers. I just sort of took a screenshot here. We're based in Philadelphia and NCC, so Temple University has a community needs assessment that's available to the public. You may be able to find similar needs assessments from hospitals and universities in your area. So another consideration in terms of some helpful data for you to look at. Next slide. So what's next on our pillars of community engagement? I'm going to turn it over to Joe from APCHO to give us a little bit more information about cultural humility.
Thank you so much, Emily, for that great overview of data as an important pillar of community engagement. So as Emily said, the second pillar of community engagement that we'd like to share with you all today is cultural humility. Before defining cultural humility, I'd like to invite our attendees today to write in the chat box specific words or images that come to mind for you when you think of the word culture. For example, for me, it's language, it could be food, music, and even gender identity. According to the Office of Minority Health, culture is defined as integrated patterns of human behavior that includes the language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Next slide, please. Many of you may have heard of the term cultural competency, which is defined on the left-hand side of your screen, which is defined as mandates, laws, rules, policy, standards, practices, and attitudes used to increase the quality of interactions within the public health system, and thereby producing better outcomes among the patient populations we serve. While cultural competency is important, it can be quite difficult to master knowledge of every person's culture. And sometimes this can lead to stereotypes, automatic assumptions, and develop implicit biases. Which brings us to our definition of cultural humility, which does not require mastery of lists of different cultures and particular health beliefs and behaviors. Instead, it entails developing a respectful partnership with diverse individuals, groups, and communities. So the key word here is humility, which is marked by modesty in behavior, attitude, or spirit. And practicing humility often requires showing patience, gentleness, and moderation about one's own abilities and values. Next slide, please. Here, you'll see 4 values of cultural humility, which entails openness, appreciation, acceptance, and flexibility. These values can help strengthen your community engagement efforts. Next slide, please. This is a cultural humility framework developed by Drs. Melanie Turvalon and Jean-Marie Garcia back in 1998. And the framework consists of 3 tenets. One is lifelong learning and critical self-reflection. So to practice cultural humility, it's to understand that culture is first and foremost an expression of self, and that the process of learning about each individual's culture is a lifelong endeavor. Secondly is recognizing and challenging power imbalances for respectful partnerships. While working to establish and maintain respect is essential in all healthy relationships, the root of effective healthcare and social work practice is in acknowledging and challenging the power imbalances that are inherent in our practitioner and client dynamics. And lastly, institutional accountability is the last tenet here. Organizations need to model these principles as well, from micro to mezzo and macro practice. Next slide, please. Here, you will see a simple framework that you can use to organize different ways you and your organization can practice cultural humility. So for example, under the lifelong learning and critical self-reflection bucket, you may benefit from motivational interviewing training, which stresses a non-expert approach as we communicate and help others. In the second bucket, you'll see an example such as making sure that the patient is the expert, reminding us to always anticipate multiple cultural identities when serving community members. And in the third bucket, you'll see an example such as hiring for diversity, so that you can hire staff with shared history, heritage, knowledge, and skill who can stop any social or cultural practices that reinforce discrimination. So with that said, I'm going to, that's an overview of cultural humility. I'm now going to transition it over to Alan Gamboa, our program director of APCHO's Pacific Islander Diabetes Prevention Program. Alan?
Thanks, Joe. First off, I wanted to thank the task force for having me today to share the work that we're doing with prediabetes. And also thanks to you, Joe, for setting the stage for cultural humility. It's such an important concept, and it's really helped us here at APCHO and the work that we do. So in 2017, APCHO became a recipient of the CDC 1705 grant and was tasked with building the infrastructure of local organizations to address prediabetes in Pacific Islander communities through the delivery of the National Diabetes Prevention Program, or National DPP. These lifestyle change programs are evidence-based and was developed by CDC. They focus on making positive changes in eating habits and increases in physical activity. Those who successfully complete the program can cut their risk for developing type 2 diabetes by 58% or more. Next slide, please. So to guide us through this work are 5 key strategic areas, and they really rely on partnerships in different sectors of the community, such as private companies, faith-based organizations, FQHCs, and CBOs. The 5 areas are increasing availability of lifestyle change programs in underserved areas, Number two, increasing clinical diagnosis of prediabetes in adults. And oftentimes this is through partnerships with various organizations like departments of health, FQHCs, etc. Increasing awareness of diabetes. Number four is targeted participant retention for lifestyle change programs. And finally, increasing benefit coverage for lifestyle change program participation through private insurers, employer-based, or through Medicare and Medicaid where applicable. Next slide, please. And to date, we have worked closely with 11 organizations throughout the continental US, Hawaii, and the Pacific region, including the islands of Palau, Kosrae, the Republic of the Marshall Islands, Chuuk, and Saipan. This graphic in the middle shows the span and reach of our diabetes prevention program. Next slide, please. Before supporting the infrastructure of our local partners, APCHO had to increase its own capacity in preparation to work with Pacific Islander populations in a meaningful way. To do so, we very intentionally utilize cultural humility and competency strategies. I've got some examples listed on the slide, but I wanted to highlight a few for purposes of this webinar, and they're the examples that are colored red. I'll start with the first example under lifelong learning and critical self-reflection. So prior to starting our work in these communities, we needed to better equip ourselves to understand and work with Pacific people. Although we've worked with the Pacific in the past, this particular project called us to work with this population in a deeper way than we've done before. And to do that, we worked with and continue to work with a subject matter expert who has decades of experience working with Pacific Islander health. As an advisor and consultant, they're continuously helping to guide us and ensure that we're conducting our work in a culturally appropriate way. The second example is under institutional accountability and speaks to our work on the leadership level at APCHO. What we did was we changed the governance of our organization and made efforts to create more seats on our board of directors to include more Pacific Islander serving community health centers. This increased representation from the PI community has allowed us to make sure the voice of the Pacific is heard on all aspects of our organizational work. Oh, can you go back, please? Sorry. So in the next example, I wanted to focus on our lifestyle coaches who are really the lifeblood of our program. We've learned that the Pacific learns best by quote unquote doing. So instead of the lifestyle coaches charging on to teach their own classes, we had them actually go through the class themselves. Sorry, that one's on the right side, developing institutional accountability. And the class that they took was taught by our subject matter expert. By experiencing the class through this perspective, they were able to gain useful teaching techniques and also better understand the challenges that their future participants would encounter. Although it took a tremendous amount of work and caused a slight delay in our program, it really proved to be beneficial for the work to come, and we've since seen many successes through this program. And the last example, right in the middle of your screen, it's in relation to creating culturally appropriate materials. We recognize that the curriculum that we were originally given didn't fit the needs of our priority populations. And to address this, we looked to our community leaders to both adapt and translate the curriculum into 3 Pacific languages, Marshallese, Kosraean, and Chuukese. This adaptation did not only take into account verbal translation, but we really looked at health literacy and even pictures to better reflect the Pacific community. And within all of these examples, there's one underlying strategy that Joe spoke of earlier that's really helped us to work so closely with the Pacific, and that's the patient being regarded as the expert. But in the context of our lifestyle change programs, the community is the expert, and we've tailored our work based on their strengths. Next slide, please. And on this last slide, I wanted to share some of the successes shown through data. I truly believe that it's because of our cultural humility practices on multiple levels that it really allowed our program to thrive and drive community change. Thus far, through our 11 partner sites, we've enrolled over 1,500 participants. There has been more than 12,000 pounds lost, and they've done over 4 million minutes of physical activity. We're so proud of our community partnerships and the work they've done in their community. Their community relations and leadership on the local level have been invaluable throughout this process. Later on in the webinar, we have the pleasure of hearing from Malama Ikeola Health Center, one of our partners who has done a great job at engaging their local communities in Maui to create healthier lifestyles. And that's it for me. I'm going to go ahead and pass it off to you, Albert. Thanks.
Thanks, Alan and Joe. We're going to dive into our third and last pillar, which is partnerships or partnership engagement, led by Miranda from School-Based Health Alliance. So I'll pass it on to you, Miranda.
Great, thank you so much. So like we said, now on to partnership engagement. Go to the next slide. So what do we mean by partnership engagement? Well, health centers provide amazing care for patients. You don't have to go it alone to provide services to address diabetes care and management. This is where partnership engagement comes in. Partnership engagement is the process of identifying and engaging with existing community resources to extend your reach and impact. Next slide, please. But why pursue partnerships? Partnerships are a great opportunity for diabetes prevention and management because they take the strengths of each partner organization and focus it on proven strategies, allowing you to reach your target population with greater breadth and depth. As this diagram illustrates, two organizations working on the fringes of a problem can be less impactful than if they're aligned behind a larger objective that harnesses their strengths, making progress and delivering the desired changes towards the goal. Next slide, please. The power of partnerships is rooted in their flexibility. Partnerships can be built to fit the needs of both organizations and the communities they serve. This flexibility means partnerships can exist along a continuum. They can be as in-depth as you and your partner decide. Remember, it's important to establish the partnership level together as it will be the foundation of the MOUs and agreements you create and defining roles. Your MOU, or Memorandum of Understanding, will help set expectations between the partnering organizations and set both teams up for successes and shared responsibilities. Thinking back to the linkage framework, these are principles that are found in the N, negotiate and agree upon goals, the K, know which operational structure to implement, and the A, aiming to coordinate and manage the link. So looking at this, this grid, you can see the continuum is going to go from our least intensive partnership type, which is cooperation, that is informal relationships with shared information only, separate goals, resources, and structures. And an example is a community center promotes health center services, and the health center promotes the community center services and events. The next step along the continuum that is a little bit more effort is a long-term effort around a project or a task. Some planning and division of roles, some shared resources, rewards, and risk. And this can look like a health center that operates as a guest speaker in a health class on diet and physical activity in a school to meet academic requirements. The most intensive partnership type on this continuum is collaboration, a durable and pervasive relationship. It involves new structure with a commitment to common goals, and all partners contribute resources and shared rewards and leadership. And this can be an MOU between a health center and a school for the health center to perform sports physical at the start of each semester. Don't be surprised if at the beginning of the partnership, your potential partner wants a more intensive collaboration-based relationship. But as time goes on and trust is built, the partnership may translate into a more of a coordination or cooperation role. Next slide, please. You don't have to start a program from scratch, and your community likely has other programs that are trying to achieve similar goals. Your community is a rich resource that you can utilize to expand your reach to target your population. This can include partnering to introduce interventions where the patient population lives, works, plays, and receives services, such as schools or health centers. In addition to identifying where to reach your target population, you can look within your community for organizations that can strengthen programs and intervention to prevent and manage diabetes, including community gardens for fresh produce prescriptions, recreation centers, parks for activities and fitness programs, existing nutritional programs that teach healthy cooking and meal planning, and food banks to supplement healthy foods. Next slide. These examples, which are a spectrum of school health service and partnerships are seen in this diagram, and they were collected from 6 intensive interviews as part of the Uniting for Young People's Success project at the School-Based Health Alliance. And as you can see, there are many ways to build partnerships that expand current services or provide introductory services to build relationships within a school setting. This can include policy, an ongoing agreement between your health center and a school that can include referrals to health center or joining the school's wellness committee. It can be an activity, participating in or organizing a specific event like a health fair, BMI screening and physical activity counseling, or conducting sports physicals. It can be an education activity, providing services that address education outcomes, such as providing an education session on healthy eating or stress management around finals or testing windows. And it can also be an academic activity, providing academic support, such as career mentoring or attending a health or science class as a guest speaker. These are examples that are specific to schools, but they do provide concrete examples of partnerships in action. And then here are a few resources. This is a page with some of our resources that are listed.
Thanks, Miranda. And these links will be available once you download the slides. My colleague Joe can type in these links as well into the chat box in case you want to access them sooner. Great, so we're going to go into our featured panelist discussion, and we are going to be led by Emily, again, as the facilitator with our 4 health center and CBO representatives. So you are in store for this treat to wrap up this session. So Emily, I'll pass it back to you.
Great, thanks, Albert. And I'm really excited for this portion of the webinar. I mean, we spent some time going through some of the didactic, pieces of community engagement, but we're really going to get to hear some great stories from our health center and community organization partners here. So I'm going to ask each of the panelists to introduce themselves a little bit. I know we heard a little bit about them earlier, but for each of our panelists, I'm going to ask them to describe their organization and the population that the organization serves, and then what has your site done to actively engage your community in diabetes management or prevention? So just going to go ahead and start with our first featured panelist, Cindy Whitlock. Cindy, do you want to just tell us a little bit about yourself and your organization?
Thank you. New River Health is located in southern West Virginia. We operate in 3 southern West Virginia counties with medical sites, pharmacies, dental sites, behavioral health, black lung, and cardiopulmonary. We also have a medical assisted treatment program that's a year old. In West Virginia is one of the states in the country. I think we are #1 in kinship homes, which is a huge concern among folks that I work with because of the state of family in our world. And our 3 counties are #1, #2, and #5 in West Virginia, respectively. And the last time we had a full school year, we served 12 schools because of consolidation. That number right now is 9. There were 5,900 kids enrolled in those schools, and we have consent from 4,600 of those, which amounts to about 20,000 visits during a school year, and that includes medical, dental, and behavioral health. Our average consent rate is about 80%. And our site, what we've done to engage in diabetes management or prevention over the years, there have been a variety of methods to deliver information to that population. It's a very high number in West Virginia. Something like 50,000 people in the state are diagnosed, which amounts to almost 150,000 visits in West Virginia for diabetes care. So we have done a variety of methods, both one-on-one counseling after somebody is diagnosed or being close, like prediabetes. We have also had diabetes classes where we've been teaching yoga and healthy food choices, those kinds of things. And what we found is the best thing that we could light on as far as a collaboration of our 40 to 50 collaborations that we have through New River Health was an active fitness-oriented program, which is free to everybody involved. So I'll stop there and let you go on to the next person.
Great. I'm so excited to hear more about those partnerships, Cindy. Thanks for introducing yourself. Our next panelist is Lizz Tooher from Nurse Family Partnership Mabel Morris Family Home Visiting Program in Philly. So Lizz, you want to tell us a little bit about NFP Mabel Morris and community engagement?
Yeah, thank you, Emily. Thank you, Albert, and the task force for having me. I'm excited to tell you more about the Mabel Morris program here in Philadelphia. So together with the Nurse Family Partnership, we serve about 750 Philadelphia families every year. Families live at or below 250% of the federal poverty guidelines. So that's about less than $50,000 for a family of 4. We know in Philadelphia that about 1 in 3 of our children are living in poverty. So $50,000 is a generous income, I would say, for many of our families. Beyond that, we're a free and voluntary evidence-based nurse-led program. We promote healthy pregnancies, early childhood development and education. And we're sort of that third space for families, support them in meeting their goals and where they want to go in their life. But the third space sort of being not family, not medical provider, though we are nurses, BSN nurses. We sort of fill this other space, a bit of a connector of many other different providers and partners in their life. So we work long-term with families. In our Nurse Family Partnership Program until the child, from pregnancy until second birthday. And with Mabel Morris, we're working with families until the children start kindergarten. So we're there from finding pre-Ks, connecting to early intervention, and connecting with any other medical or social need that the family has, really treating the whole person and through the lens of the parent and child. So we understand that building families comes from families recognizing their strengths, and that those strengths are the things that can counter risk factors. We like to say that we can find the fire inside a person and help them burn that hotter and brighter. We receive referrals from many different organizations around the city, managed care organizations, community programs, local OB providers, early intervention providers are good partners. Immigration services also can be great resources for us as well. Let's see. We work in the home, meaning that nurses are working closely with families to assess what actually is available to them and what are the barriers. Our nurses are able to see the neighborhood, to see the block that the family's living on, and what they identify as some of their assets. That allows us to help start to build some healthy habits right from the start for families, securing accessible medical homes, promoting health and wellness practices that really underpin some of these long-term outcomes. So I can keep going, but I'll freeze there. And thank you again for having me here today.
Great. Thank you, Lizz. And then we have Malia from Clinic of Maui, Malama Kalia Health Center. Malia, can you share a little bit about your organization and community engagement?
Yes, of course. Aloha, everyone. Mahalo for having us to be a part of this webinar. My name is Malia Purdy. I'm the Director of Programs at Malama Keola Health Center on Maui. We are one of 2 FQHCs on the island, and we have about 3 sites that deliver services and 15 providers. And so our services include medical, which include adult, pediatrics, and OBGYN. We have mental and behavioral health, substance use treatment, oral health, pharmacy, and enabling services, just to name a few. We serve about 1,200 patients a year, and 65% of them are on Medicaid, and we have about 20% uninsured. 56% of our patients are at or below 100% of the federal poverty level. And our ethnic makeup, as you can imagine, is very, very diverse. We have about 10 to 50% Native Hawaiian and other Pacific Islanders. And that is kind of the vulnerable and priority patient population that our work is geared towards serving. And so with that, you know, in terms of what we've done to engage in diabetes management and care was engage in that Pacific Islander DPP program that Alan had mentioned before. And so a lot of our work has been to this population of OFA migrants that are to Hawaii to get education and healthcare. And I will leave it at that.
Great, thank you, Malia. And finally, we have Saida from Golden Valley Health Centers. Can you share a little bit about yourself and your organization?
Hi, can you hear me? Oh, wonderful.
Yeah, can hear you.
So, wonderful. Golden Valley Health Centers started as a program at the Merced General Hospital, I think in the 70s, because we're 40-something years old, almost 50. Our services include, of course, first family clinics. We have pediatricians. We also have dentists, behavioral health. In December, we started a chiropractic department. We also have orthopedics. We've expanded to that. I work as a health educator. So as a federally qualified health center, the patients did not pay to see the health educator. Was considered an extension of the medical visit. We also have medically assisted treatment. We call it MAT, and a substance recovery counselors. We have a handful of those. Many of our patients are Medi-Cal, about 60% of our revenue. And we had 40 clinics, over 40 clinics among 3 counties, Merced County, San Joaquin County, which is where I live and work, and San Joaquin County in the Central Valley. And that's it.
Great. Thank you so much for sharing that. And so we're going to take the remaining few minutes of our presentation today to really engage our panelists in some discussion about community engagement efforts, you know, at their organizations and just in their larger work in the community. So we're going to start with a question for 2 of our panelists. I want to ask, what has been sort of what have been the best community partners in your efforts and why? And I want to start with Cindy from New River Health.
Well, I'm looking at my list of all the people that we collaborate with, and we've tried programs to keep people active, which I said is what we kind of lit on as the best way to help patients with diabetes and help guide those who are pre-diabetics away from that chronic disease. And when I look at, the thing about collaboration is it's very hard to keep that ball in the air and keep the enthusiasm going and the new programs and whatever your goal is, it's very hard to keep that level of enthusiasm out. So our shining star in Southern West Virginia is Active Southern West Virginia. It's activeswv.org. They are also on Facebook. And what they do is work to build activity programs and events which are free to the public. And they train community captains in the Southern West Virginia area to take these on. So every month we get a calendar from them, and everything on that calendar, whether it's swimming, aerobics, hikes, anything like that that's active is on there. And we make sure in school health, at least, that all our providers have that information and that they can put that calendar into the chart or into the information that the patient or child receives or his or her caregiver receives. And that way, the hurdle about money. Like everybody says, if you're working in an FQHC, your patients are not wealthy people. So joining the Y or joining the fitness center is not an option. And geographically, they're probably not located near one. So hiking, walking, riding a bike, those kinds of things, which don't cost anything or cost much, are things that they can all do. Now, with kids, what we have done because I'm also doing the marketing at New River Health, I get the opportunity to kind of gear the sponsorships we have toward the organizations that I want to support that are doing this kind of thing in the community. So we sponsor what they call fun runs, which are at the schools, and they are not a interscholastic sport. They are everybody can do this kind of sport. And we provide the water. We usually do a BMI pre and post 6-week program. And at the end of the program, the kids all get together at one place locally and have a big field day together. But there's no cost to any of the kids because there are sponsors like us. And we're hoping that what all of us see, I'm preaching to the choir, is when you look at a child who is overweight or obese, you can imagine the family standing behind that child looking the same way. So you're not just dealing with a child, one obese child, you have to hit that family with something that they can all do together, whether that's running, walking, riding bikes, or whatever. The other thing that they do is sponsor events. They do a family triathlon, which locally includes running, biking, and a watercraft. So it may be a kayak, it may be a raft, which is on a flat water lake. And they do a more challenging triathlon for more athletic type people, which includes going down the rapids in West Virginia, as well as running up a very steep mountain and riding bike through a very treacherous bike trail. So we have the run clubs in all the schools where we have clinics, and we try to connect the information. If there's a red flag in our diabetes pre-run thing that we do, the BMI check, we make sure that the medical provider at that site knows that. And we also connect those kids to our mental health provider because as you know, all these weight issues connect to depression or poor body image, or in some cases, as ACEs originated, you all know that basically in the beginning was a study of overweight people and how they reacted to losing the weight. So all of those things kind of connect. So I just encourage you to go Facebook or look at their site. We stole that from another state. I think it started in Virginia, and I'm on the board of directors for that group.
That's great. Thank you for sharing that, Cindy. And then from Liz, I want to hear an answer to the same question. Liz, as a non-health center, as a community partner and organization, what have been the best community partners for you all at Mabel Morris?
Yeah, well, I think I have to go right off of what Cindy said and say that, our nurses would come into the home and use those materials, connect with families and say, you went to that FQHC appointment, did you bring the paperwork? Do you want to review it? Then once we see the calendar, we might say, are there 2 or 3 that are standing out to you that you could see yourself doing? And then our nurses are back 2 weeks later to say, how'd it go? Did you guys do that jog around the block? Or, well, I said I would bring my sneakers, so what do you think? Should we do it today? Are you up for that? You want to do it? And I'll check in at our next visit. So connecting to resources that are already in families' hands instead of always trying to bring a new resource. And using open-ended questions, too, are not community partners, but way to help families engage with the work of our other community partners. So some of that motivational interviewing, meeting families where they are with just one small step, or, finding one on that calendar of 30 that you could try a couple of times that month, even just to get started. Or something else that would work better for you. What's worked in the past? What hasn't worked in the past? Why do you connect or not connect to this calendar? And starting there, kind of getting to those deeper reasons, maybe.
That's great.
Thanks. I think also, just the ones that the clients are already connected to are some of our best community partners. Here in Philadelphia, we have Smith Playground. That's a giant free playground and little giant mansion in the park. It's accessible to public transit. Families have been going there for 100 years. And we just started emailing them saying, hey, if we, you know, brought flowers and little terracotta vases around Mother's Day and planted flowers, could we come have a picnic in the playground with you? And they loved it, and they were really into that. And we were able to bring pulse oximeters, monitors, and trampolines, and check people's heart rates and pulse ox and kind of educate on that. So not always making the health education the forefront. The event was really Mother's Day, but sliding it in as a side dish.
Great.
Organizations doing the same work or similar work, especially if they have money. You know, what do I have to offer them is direct contact to families. And a lot of times people are looking to partner directly with families. So, you know, how can we make an exchange here that I can connect you directly to families and you can offer us something in exchange? So, for example, it could be, you know, if you're working at the policy level, a lot of times something going on at City Hall, they might want to quote or a family to come and speak to an issue. So if we could find out a way to, you know, in return have a payoff for our families through that exposure, that's a really great benefit too, or some kind of engagement that way. Same goes with organizations that are facing the same challenges. So Philadelphia organized the Community Action Network, which is a coalition of providers that organized to create a central call line so that if you want to refer a family to a home visiting program in Philadelphia, you don't need to know the phone number for the 20 some odd different programs. We now have one central call line, and any provider could call and make a referral that way, and the family would be flowed to the appropriate program. So sort of just making things accessible and seeing what the needs are of your exact population, and then coming together to find ways to work together to address them.
Thanks, Liz. That's great to share that example of a call line, something that I think might be, I would love to hear in the chat if others have found that they, that could be useful in their community, or something similar has been established in your community. Moving on to another question, I want to ask Malia, actually, what has been your biggest obstacle in engaging community partnerships, and what strategies have you used to overcome these obstacles? Malia, I wonder if you can speak to that a little bit.
Yeah, so our biggest obstacle in engaging is we've been at our current site permanently for 10 years now, and so we're still finding that a lot of people don't know who we are and the kind of services we offer. So it's been a lot of me reaching out and connecting with all the community partners that surround us physically. You know, just in our neighborhood that is easily accessible because transportation is an issue for our patients, and what kind of resources do our community have? On that greater scale, I think it's worth mentioning that FQHCs have so much to offer our little nonprofit organizations that are trying to thrive on our islands. And what I mean by that is our small CDOs that are grant funded or have seed, they don't have the capacity or the staffing to write grants to support the good work that they're doing. And these are like farmers markets, you know, school fun runs that was mentioned. You know, there's not a lot of bandwidth to grant write and stuff. And so that's a way that our clinic has partnered with small organizations in trying to support grant efforts of these small community organizations. So it's really that collaboration between orgs. The second thing is as I mentioned, the COFA migrant, the Pacific Islander population who is coming to Hawaii. Our health center literally started from ground zero. We have no background about how the customs and traditions and of these new patients that we're seeing, there's a lot of communication barriers. There's a lot of kind of traditions, I guess, that we're unaware of, such as males can only speak to males and women aren't allowed to address a male in a clinical setting. So learning all of those kinds of things were huge barriers to engaging our vulnerable population that we're trying to address. And so for that, we actually held these community town hall meetings specifically for Pacific Islanders. And we got them together in a room and told them, how can we best help you? What kind of services are you looking for? Like we just had no idea. And what came of that was actually hiring a few as community health workers. And so now we have this force of community health workers who are Pacific Islanders, and we're actually hearing the needs that need to be met from these actual community members who are part of the community that we know nothing about. So that's just, kind of our challenges and what we have done to overcome.
Yeah. No, that's great. Thank you for expanding on that. And actually, it leads to another question that I kind of wanted to ask about that cultural humility piece. Saida, I actually want to ask you, how do you ensure that your interventions meet the cultural needs of the populations you serve? So for example, when Malia was talking about, not having the information about some of the cultural practices that their patients were engaging in, how do you sort of address that and even find out about what some of those, what some of those needs are?
Yes, thank you. So I was listening to Cindy and Malia, of course, and sometimes the obvious is not obvious until someone points it out. So for example, one of our centers, we have at least 3 school-based health centers. So the one at Hanshaw Middle School, the way to get into the clinic is you have to go into the parking lot and go behind the school where the teachers park. And then way back there next to the canal are 2 portable buildings. One is for the medical side, Golden Valley Medical, and then Golden Valley Health Center's dental. But people don't know it's there until somebody tells them that it's actually, you have to go into the school parking lot and then go behind the school. So, it's word of mouth. And then the other thing is the Salvation Army has an outdoor pool, but there's a concrete wall right there. And as you're going into the school parking lot, there's the concrete wall is on the right-hand side. And on the other side of the wall is the open pool. They charge about $1, I think, for the kids to go into the swimming pool, but it's free. It's in the community. A lot of that neighborhood does not have sidewalks, so there's potholes, and I was joking one time that we needed canoes to get to work because it was so flooded over there. So like Cindy was saying again, it's knowing what's in the community so that you can get to it. So to answer your question about the challenges and the solutions or interventions is these health fairs that happen in the summertime, or usually April and May, that might not be happening this time around because of the coronavirus situation and, us practicing social distancing. Some of the challenges, again, are transportation. So even though it's been in the community, the participants that might benefit from it might not be able to walk, 10 or 15 blocks to get to it. Language and culture, health literacy and numeracy, the time of day. So a lot of people work, with their hands or entry-level jobs or what have you. So they're probably working on Saturday morning when these health fairs are happening, or classes, whatever. Some of the solutions to go around some of the barriers, not all, that Golden Valley Health Centers has come up with is somehow, we had bus passes for patients. So they had to make it to the clinic and then they would get 2 bus passes, one to go back home and the other bus pass to come back to the clinic for their follow-up. The other thing that I recently found out in the last 2 months that Golden Valley Health Center was doing is going through the patient's insurance and Golden Valley setting up an Uber or Lyft to bring the person to the clinic to get seen by the doctor or what have you, and then calling the driver, a different driver back to take the patient back home. And so in order to maximize the visit and the patient's time, we would oftentimes, for example, myself, I would offer a foot exam while the patient was in the exam room waiting for the doctor. So if it was like a hospital follow-up, if it wasn't too complicated, the doctor would have to review the facts. The medical assistant had to go request the facts, and then the doctor had to review it. So by then it would be like a 15, 20 minutes that the patient was already idle. So might as well, offer another service that the patient might benefit, whether it be depression screening and then a same-day appointment with the clinician, or an appointment with the health educator to talk about healthy eating. And so these, we're pointing as the best practice recommendations by the ADA that the person needs to be offered, foot exam, depression screening, et cetera, cholesterol.
That's great. Thank you for sharing that. I think one of the things you brought up was really interesting is that, when patients are coming in for these well visits and are, maybe sitting there, for 10 or 20 minutes waiting for the provider, that might be a great time to really engage the patient and provide community resource referrals, or, otherwise talk to the patient about what some of their needs are. It seems like that might be a great strategy. And I like that you brought up health fairs, and I know Lizz and Malia talked about other town halls and outdoor sort of events and things like that. I just wanted to ask one thing that's not on the slide, and any one of the panelists can answer this. In terms of these events like town halls and group events for your patients and communities, what has been the process of putting those events together, and how did you decide to start those events? And maybe we can start with Cindy. Actually, I don't know, Cindy, if you all have experience with that in West Virginia.
Yes, I do a lot of health fairs that other people do.
Right.
So if they're doing a pre-K registration or kindergarten registration or back to school orientations, we show up at all those. That's one of the key elements, because you can get to the family with those kinds of things. And we did one health fair in 130-degree temperatures and 100% humidity in July one time, and we haven't done one since, because it just seems like everybody's doing a health fair. And I can sponsor, I can take. The challenge is that your providers are all billable people who aren't going to be present at those kinds of things, especially in the summer. If they're school health providers, they're not going to be on the payroll, so to speak. So I find it kind of limiting, but I did entertain a thought last year about having one at one of the bus stops during Bridge Day. So I may try that again this fall.
Great. Thanks so much. Anyone else want to weigh in on those events? And also wanted to ask you all if and how you're engaging social media in some of these efforts as well. I know Jody in the chat box brought up utilizing a Facebook page to get some engagement that way. Would love for any of our panelists to speak to that as well.
This is Saida.
Go ahead, Saida.
One of the things that Golden Valley, thank you, that Golden Valley has started doing is patients will get something on their a text on their phone to submit a survey, and then and when I took my grandmother to Golden Valley Health Center, I got an email asking us to rate a Golden Valley Health Center, and then that would be posted on Google Review. Thank you.
Oh, great. Wonderful. Thanks. Was someone else going to answer as well?
Yeah, Malia.
Malia.
So what we've done actually is the Pacific Islanders we found are strongly faith-based. And so we went into churches, and that's how we recruited people to come to our town hall meetings. So that's been very effective with our priority population. And then just by chance, Facebook is also the main way that they communicate. And so our lifestyle coach is part of our DPP program. Everyone has a Facebook group for their lessons and content and chats. So that's a way that people engage to keep each other accountable. So Facebook has been very, very, very useful for us.
Great. Thank you for sharing that. One other.
This is Liz.
Go ahead, Liz. Yep.
Yeah, I just wanted to clip on that. I would say anything you do try, don't abandon, tweak things and retry them. Make sure you're talking to your gatekeepers and the people that really know your community that might be able to inform your project before you just say it's not working or you're not getting enough likes. Really relook at things, relook at funds you might have to invest there and put some dollars behind these efforts. And committing staff time too. We started today talking about the evidence of how vital this is, but I think sometimes these efforts are sort of seen as being voluntold or sometimes just the extra stuff. But I think we know now that this is a pillar. This is vital to our families and our clients' success. So really putting that power behind your community engagement too.
That's a great point. Thank you, Liz, for bringing that up as well. I want to ask one last question before we wrap up our panel for today. Many of you talked about, some of the interventions that you've been using at your health centers and your organizations, and also, learning some of these cultural factors about your population. How do you use data to identify, some of those elements? And I particularly want to hear from, I know you didn't put this on your questions, Malia, but how do you find out, for example, some of those cultural considerations that you really need to have in mind when you're engaging your patients? How is that data collected, or how are you, understanding that information?
Yeah. So for us, luckily, we are part of ACTUAL's PI-DPP grant. And so we went from ground zero, knowing absolutely nothing about this new priority population, to all of a sudden being connected to this network of communities. On Maui, it's different because we're trying to address Kosraean, Chuukese, Marshallese, all these different Pacific Islanders who are on Maui in Hawaii, right? A culture that is totally and completely new to them also. What the network did was expand. So now we have Kosraeans in Kosrae to get information from. We have Marshallese in the Marshall Islands that we can now get information from. And the thing about the Pacific, is they're all over the place. Everyone is connected. Everyone has family. It's a small, tight-knit community. You kind of know everyone's business, whether that's good or bad.
Right.
But that's how we've kind of been surveillancing and anticipating the needs of what our community here on Maui needs to focus on. So in addition to, we have that kind of network going on. And then in addition, we also have all of our data's in the charts that we see. We have access to the electronic health records. And so we're constantly looking at, the health needs. And so that's kind of why the DPP project made total sense for us, because this is a huge at-risk population for diabetes. And so to catch them when they're pre-diabetic, that would then, increase their health outcomes later on down the road if, instilling these healthy habits in them.
Absolutely.
Yeah. So it's really a, collaboration between our networks who are international and then also our local health center data that we're getting. And then of course, through the CHWs, we're constantly asking for feedback. Okay, how are your patients? What's the need? And just constantly checking in with them on a weekly basis to see if we should be creating new programs or really fostering the ones that we already have.
Great, thank you. It seems like, the utilization of community health workers or, to Lizz's work, maybe home visiting programs, those might be really powerful partners or staff that you can use to learn more about the community, so that when you do decide to offer programs or you do decide to do an event, for example, you have the information that you need to really maximize those opportunities. So that's great. And Saida, I think we wanted to end the panel with you just talking a little bit about, your diabetes management screening efforts at the health center. I know you provided us with some of these samples, and I think there's some great things to share here.
Thank you. So this is looking at data in a very macro, like individual level for the patient. The first picture here is an iteration that was developed and tweaked from an intern that we had. So they had Barbara looking at, again, the best practice recommendations. So there's a handful of boxes here that we would use this tool as conversation with the patient to talk about prediabetes. So, you know, here are the ideal levels for the blood pressure in this middle box, second column. Then underneath that is we also have an optometry department, so I forgot to mention that. So just a reminder that diabetes does affect the eyes. Then we go to the next column, background, family history, if you're any Hispanic, African American, Asian American, Pacific Islander, and then they could either circle. I would usually have them circle instead of having them handwrite what their background is. And then the blood glucose test would be usually, yes, the A1C or fasting numbers. So this is probably the reason why they were sent over to talk to me. And then if you skip all the way over to the bottom right, lipids profile, I explained lipids is another way for fat. And so we would spend a bulk of our 20-minute conversation talking about the bad fat, L is for lousy, triglycerides, which is the type of fat, and then the good type, H is for healthy. So that way they could be linked to the way that we talk, you know, LDL, L is for lousy. Okay, I don't know what it means, low density lipoprotein, but I know it's the bad one, right? And so bad, I explain, is just a name because it refers actually to saturated fat. So I have them, you know, to engage them into their own health, handwrite what their value is according to what I see on their screen and that's in the electronic health record. And then my goal is what is the ideal. So for the LDL, the goal would be 100 or less. And so sometimes I would even go over when they were done and just put happy faces, you know, because by the time they get to the car, you know, after the 20-minute conversation, sometimes, you know, it goes in one ear and out the other. Next picture, please. So with the new administration for Golden Valley, we decided to redo it. And so instead of having one sheet of paper that's in English on one side and Spanish on the other side, we decided to separate. So this is the Spanish new brochure, and it has portion sizes that the other handout did not have. And then next slide. On the inside of this one, this one's printed in cardstock. It has the pre-diabetes test on the first two columns, and then the last column, it was the whole other handout put into this one column. So you have the A1C, first row, the second row would be the fasting sugars, third row, third, fourth, and fifth row would be the lipids little box. So these are shaded in blue and green, which are agency colors, so that the person is able to still handwrite and be engaged in their own numbers, and then the ideal numbers on the other column. So one of these, you know, going over these, this few, I don't know, 6 rows takes me a good 20 minutes in the conversation because we're looking at real life examples, their lifestyle, you know, a stay-at-home mom with 3 or 4 kids taking care of her elderly parents versus a truck driver versus a dairy worker. You know, we have to find examples for them to take their lunch, prepare their lunch, eating out, and things like that. Thank you.
Thank you, Saida. Yeah, I think I love the idea and you know, bringing up that we have to make sure that we're bringing tools and resources that are appropriate for our patients' experiences. So, you know, obviously, maybe resources for that stay-at-home mom versus the truck driver, knowing that those are going to be different needs. How can we bring our partners to bear and our resources to bear in both of those situations? So
this is Saida. One more thing, that I wanted to bring up that is sometimes not in either one of those handouts that is a criticism from myself is the mental health component. So I see here on the comments that somebody's asking about ACEs. So we usually just do the PHQ and then refer them out. So we do have grants, but we also have shortages of professional trained people that can meet the patient and talk to them. And then there's also, you know, the stigma that the patient brings. You know, I'm not crazy. I'm just, you know, going through a phase in my life. You know, well, this phase has lasted a good 10 years, you said. So let's try and see how your mental health is affecting your physical self. Thank you.
Absolutely. Thank you. Great. So I think we're going to transition into Q&A. I know a couple of questions have already been answered, but we're going to keep everyone muted at this point, just to, you know, for clarity. But we want to turn it back over to Albert, I think, for just some end of webinar housekeeping. And then also, again, feel free to type in your questions into the Q&A pod. And if we don't get to answer them here live, we will certainly do that, answer them via email after the webinar. So Albert, do you want to go over some of these last minute things?
Thanks, Emily. We have 1 minute to spare. And so just want to do one more reminder to fill out the webinar survey that's going to pop up on your screen after you leave the meeting, especially if you're going to register for the CMEs, CNEs, and certificates of attendance. Our colleague at Migrant Clinicians Network will be using that information to send it out within about a week or two. So please be on the lookout for a separate email or regarding the CMEs, CNEs. So this fourth and final webinar does conclude our 2020 National Learning Series, which has been recorded and will be made available in our follow-up email to you all. You can also visit diabetes.apsho.org, and all these slides and recordings for all 4 webinars will be available within the next 48 hours. And that is it. So thank you all so much for your engagement. I want to thank our faculty and our panelists. I encourage you to type in any burning questions you have for our panelists, and we'll make sure that they are able to respond to them, and we'll upload a Q&A or FAQ sheet to the diabetes.apsho.org website so that you have responses to your questions from our experts. And if you all have any resources to share, please forward it to us as well, and we'll distribute them on our webpage. So with that, thank you all so much, and please stay well and safe.
Thank you all.
Thank you, everyone. Albert, there was one question coming in about the ability to get contact information for the panelists.
Oh, yes, that will be included in the follow-up email. So for those of you who have, again, registered with your email, that'll be available. And I can also, make sure it's available in our FAQ document. That's going to be on the follow-up email. So it'll be soon to your inbox in 48 hours. Thank you.